Hi, Samad. Good to see you. Hi, Samad. Can you hear me? Oh, you're muted, sir.
There you go. There we go. Can you hear me now?
Yeah, I can hear you now, everybody.
Wonderful.
Can you hear me too?
Yes, very well.
Good. Okay.
Jester, you there? Who is supporting us? Just
Oh, still coming in.
Is the technical team there with us?
We're always critically dependent on technicians, that's for sure.
Dr. Mahwish Ahmad, welcome. Can you hear us?
Yes, I can.
Oh, thank you. So we are all three together. So that's wonderful. You're not live yet. So are we good to go? Can we start? Yeah. Okay. Give us a go ahead when you want us to start. Call management team, you are muted. Okay, it's 6 o'clock.
Go ahead and start now, Doctor.
We can start. Right. Thank you. Okay, thank you very much. This is a very important webinar that we have put together with the help of World Federation for Neurorehabilitation and Pearl Events Management. I'm Sabat Wasti. I'm Director of Neurorehabilitation in Cleveland Clinic, and I'm also chair of Special Interest for Ethics in World Federation for Neurorehabilitation. We are particularly honored to have with us today two very special speakers. Professor Volker Homburg has very kindly agreed to join us today to support the event, essentially. And he is going to just say a few words. He's president of the World Federation for Neurorehabilitation. He comes with a long credentials of immense academic achievements. He is, if you may, mentor for a lot of neurorehabilitation physicians across the world. I have personally known him for over 15 years, and I've learned a lot from him. He is a very intelligent brain of neurorehabilitation, and whenever we are in a little bit of a quandary, he's the right person to approach. So without further ado, Volker, can I ask you, Professor Homburg, to give us a little piece of wisdom with respect to ethics before I kick
Okay, first of all, Savas, thank you very much for these extremely kind words. It's difficult if this really applies to me, but well, I take it. First of all, thank you very much, and also Cleveland Clinic, Abu Dhabi, and the Pearl Management for bringing this about. For the World Federation, we have a growing interest in the field of medical ethics. Do you have my presentation ready, or should I share the screen? I sent it. We could try
Share it
screen
on the slide.
sharing. Yeah.
You can go ahead and share your presentation.
You have it?
Okay, we will share it from our side.
Yeah. Can you see my screen?
No, we can see you very clearly.
That's good. That's better than the screen. Probably. Okay, never mind. I can I can briefly go over that, what I want to say, even without the slides, if it's difficult with the screen sharing at the moment. Sometimes I have difficulty in doing that.
Try sharing the screen, Volker, and
Yeah, I can try again, but sometimes it's.
You sent the slide to the management team?
Yeah, I sent it. But if it's not there, never mind. Obviously, these.
Okay.
No, you can see it?
Yeah, we can see them.
Okay, here it is. Sometimes it's a little cumbersome with the screen sharing. I don't know why. You know, the mission of the WFNR is to advance research, education, and clinical practice in neurorehab throughout the world. We do this. Next one, please. We do that by multiple means, and the goal, of course, is improving accessibility and services for neurorehabilitation, and we do that by multiple means. The question here, next slide, please, is on medical ethics. And when you go back to history, whenever people started to do medicine, they also had an idea about the ethical principles behind that and the moral principles behind that. One example, of course, is the Hippocratic Oath, going back to the 6th century, you see. And the first code of medical ethics actually was written up in the 5th century AD in this Formula Comites Archiactorum. And especially in the Islamic world, a lot of scholarship was invested into aspects of medical ethics. Ishaq Ibn Ali al-Ruawi, in his Conduct of a Physician, and Avicenna's Canon of Medicine, and all al-Razi's work was very much centered around medical ethical problems. This later on, the Jewish tradition, Maimonides did a lot of work, and in Catholic scholastics, medical ethics has always been a major issue. Next slide, please. The formalization of medical ethics as an emerging concept goes probably back to Thomas Percival, who coined this term, medical ethics, in the early 19th century. Wrote it first up in 1794, and then in a longer version of the paper in 1803. And today, our standards, if you like, on medical ethics were very much influenced by this book in 1987, published first by Beauchamp and Childress, from the United States on principles of biomedical ethics. The progress in this sense was that, you can think of ethics in a broad, very broad and deep religious, philosophical, and moral way, but you can also try to make it more universal and more easy to understand, and also more easy to debate on this by just concentrating on principles. And next slide, please. The two of them, they came with four major, let's say, principles of ethics, and more or less, they are accepted worldwide in a very broad sense. There are, of course, differences in thinking about medical ethics across cultures. In China and Japan, in other areas of the world, of course, and also in the Islamic world, the principles of medical ethics may be pertinent, but they may be interpreted in a somewhat different way. Nevertheless, these four general principles: one is the respect for autonomy, so that means the patient has the right to refuse or choose the treatment. the idea of beneficence, doing whenever possible that a physician or a clinician should do an act in the best interest of the patient, avoiding, on the other side, non-maleficence, to avoid harm, this nil nocere, the old Latin word for that. And of course, the justice aspect is important concerning the distribution of scarce health resources and the decision of who gets what treatment. And let me bring that briefly, next slide please, on our aspects in medical ethics concerning WFNR, what we do in the World Federation. I just want to point out some aspects which I think are burning or interesting or important problems in the ethical context. One, of course, is to deal with patients with diminished states of consciousness, which primarily affects the autonomy issue of ethics. The use of brain-computer interfaces may also raise problems of autonomy of the patient. The use of implanted brain stimulation devices may affect autonomy, beneficence, and non-harming as well. The availability of services and the just allocation of resources, of course, is a critical issue, applying especially to the justice aspect of ethics. And more, the use of artificial intelligence is becoming more and more problematic, affecting maybe autonomy and non-maleficence as well. And of course, health economics and ethics is a really important problem. And we discussed that over the last couple of weeks many times. And WFNR, together with Dr. Wasti, as the SIG chairperson of the ethics committee, are going to address this. And also the guys being interested in neuroeconomics will also join this endeavor. So I look forward very much to these very interesting webinar. This is all I want to say for the moment, and I'm happy to join into the discussion. Thank you so much.
Thank you. Thank you for that brief but very important contribution, Volker, and thank you very much again for joining us. And that takes me to my own presentation that I'm going to talk about. So we have chosen, as Professor Holmberg has just shown you, there are several aspects of ethical concerns when we practice neurorehabilitation. And we have chosen one very complex one today, about the ethics of dealing with patients with disturbance of underrepresented patients or individuals with disturbance of consciousness. So I will share my screen and let me get it right. Just trying to find my. Okay, we are here now.
And then go back to Zoom.
We're good here now. Okay, so can you see my screen?
Yes. Go on full screen.
All right, thank you. And can you hear me correctly?
Yes.
Okay, so the title of my talk is Adhering to the Basic Principles of Ethics During Rehabilitation of Underrepresented Persons with Disorders of Consciousness. I'm staff physician and medical director of neurorehabilitation at Cleveland Clinic, Abu Dhabi, vice president for World Federation for Neurorehab in Gulf region, and chair of Ethics Special Interest Group. So for that, I have no disclosures pertaining to this talk. So the objectives of today's talk is the background of ethics. You had heard a little bit from Professor Holmberg, a little bit of a very brief history. I'm going to touch on it, a little bit of ancient history, but not modern history. Principles of ethics that we apply, the unrepresented person with disorder of consciousness, who they are and why we consider them unrepresented, duty of rehabilitation team to that person, and application of the basic principles of ethics in neurorehabilitation of persons with disorder of consciousness. So as I know that we have a large audience, over 500 joining us this evening, and with varying degree of understanding of ethics. I thought it'll be useful just to go through a little bit of basics. So what is ethics? What it exactly entails is a part of philosophy dealing with morality. And moral is search for an inner standard, which is basically considered to be right. Moral principles that govern a person's behavior or conducting of an activity, and medical ethics also enter into question a code of ethics. So it's written, as you've just heard, there are medical sort of written codes for a medical practitioner from several centuries ago, and we are still updating them. And then the Kant's categorical imperative that he says that the individual shall act in a way that this action can be regarded as general law. So he's putting a very high standard on a human behavior in saying that it should be so proper that it should become a law to act in a manner which is right for himself or herself as well as to the society. So we're going through the very quickly history, as you've Professor Holmberg has already touched on it. In the Western literature, it is widely accepted that the founders of ethics were in Greek times, essentially Socrates, Plato, and Aristotle. And Greek philosophy predominantly dealt with moral virtue. Values are natural rather than conventional, so they expect people to act with values, and ethics is a science which should be practiced by humans in their daily life. Saint Augustinus, when it came to the Catholic and to the sort of Christian thinking, Thomas Aquinas incorporated the ethics of Greek thinking, and then attainment of happiness he added to that, and God-given natural order. He pursued that a person who is at the top of the order has a command over the society and can make moral judgments about the conduct of others. With the modern ethics, as you've heard, started with the 18th century and sort of consolidated to the 18th and 19th, and particularly after the Second World War, or after a few of the disasters that happened in clinical trials that I don't have time to go through that, a firm basis for ethics were formed, particularly for the medical practitioners. There are different forms of ethics. Value ethics deals with the degree of importance or significance of things or actions. Existentialistic ethics, a philosophical belief that we are each responsible for creating purpose or meaning in our own lives. Bioethics is interdisciplinary study of ethical issues arising in the life science, healthcare, and health and science policy. Marxistic ethics, which is also referred to as Leninist ethics, is a materialist morality as a property of man's behavior, is conditioned by his social and historical existence. And then theological ethics, as we have already touched, is a branch of Christian philosophy that engages in a reasoned analysis of ethical issues from the standpoint of Christian theology. However, there are the traditions that we already heard of ethics existed in the ancient times and other societies too. In India, for instance, Charaka clearly outlined 4 ethical principles for a doctor: friendship towards the sick, sympathy toward the sick, interest in cases according to one's capabilities, and no attachment with the patient after his recovery. The Charaka Samhita emphasizes that value central to the nobility of the profession. Thus, those who trade their medical skills for personal livelihood can be considered as collecting a pile of dust, leaving aside the heap of real gold. Furthermore, he who regards kindness to humanity as his supreme religion and treats his patients accordingly succeeds best in achieving his aims of life and obtains the greatest pleasure. And Confucianism and Confucius is a very eminent Chinese philosopher, and one I would kind of invite people to learn more about it, because most of his teaching is about humaneness. Ran, as his creed is called, is the Confucian virtue, denoting the good feeling of a virtuous human experience when being altruistic. It is exemplified by a normal adult's protective feelings for children. It is considered the essence of the human being endowed by heaven, and at the same time the means by which man can act according to the principle of heaven and become one with it. Yan Hui, Confucius' most outstanding student, once asked his master to describe the rules of Ren, and Confucius replied, "One should see nothing improper, hear nothing improper, say nothing improper, do nothing improper." And then he defined Ren in the following way: wishing to be established himself seeks also to establish others. Wishing to be enlarged himself, he seeks also to be enlarge others. And another meaning of Ren is not to do the others as you would not wish done to yourself. So Ren is basically a very important understanding component if you want to apply in a patients with disorder of consciousness, especially the last principle, not to do to others as you would not wish to be done to yourself. The possible first formal documents, detailed documents on medical ethics, as Professor Holmberg referred to, is by the Muslim physician, was laid down in 9th century by Ishaq ibn Ali al-Ruhawi, who wrote the Adab al-Tabib, which is basically translated as the conduct of a physician. The first treatise dedicated to the medical ethics. He regarded physicians as the guardians of souls and bodies, and wrote 20 chapters on various topics related to medical ethics, including what the physician must avoid and beware of, the manners of visitors, the care of remedies by the physician, the dignity of the medical profession, the examination of physicians, and the removal of corruption among physicians. And it is very important development that he actually established is the critical analysis of a physician's ability to perform his duties. The first documented description of a peer review, for instance, process is found in the Ethics of the Physician in his book of Al-Raha, where the notes of a practicing Islamic physicians were reviewed by peers, and the physician could face a lawsuit from maltreated patients if the reviews were negative. So this was the first kind of development of medical legal aspect of medical ethics. So what are the principles of ethics? As you've already heard, is autonomy of the patient, beneficence, non-maleficence, justice, and trust. I've added trust to it because in rehabilitation, we really do require a lot of trust to build between the patients, their families, and the treating team. So the Hippocratic Oath, I will just quickly take you through, and I've kind of highlighted it in different color. The first black part of the Hippocratic Oath is by who you actually take the oath for with. So in the Greek mythology, the healer by Asclepius, by Hygieia, and by Panacea. So these were the goddesses they used to actually take the oath by. The first green part is the duty of a physician to the one that he has learned the art of medicine or a knowledge of medicine. The second, the red part of the Hippocratic Oath, is the one that the medic has, or a physician has, towards their patients. And then the blue one is about data protection, if you may, keeping secrets, not actually divulging patients' matters to wider public or for wider knowledge. And then the final bit of in the black is about saying that if I don't stand by this oath, then and I transgress it, then I should be unblessed, basically. So this is the kind of little bit of a description, and it's just going on the same thing: obligation to heal, not to do any harm to the patient, not to do procedures if not trained to do so, and send for such procedures patients to those who are trained to do so, not to administer lethal poison or even advise about it, not to carry out abortion, although this is not part of in most countries now, particularly in the West, protect patients and his or her family secret. Will to respect the teacher like own parents, sharing one's life's earning to help teacher, treat his family as own and his sons as brothers, and medical teaching to own sons and the sons of the teacher. So it's a kind of a community, it looks like, that the Hippocratic Oath would like of the medical physicians and practice, within which the development of the future and the past continues. However, what comes in the capitalism and comes in the corporate. So our problem the day we live in is that we have to balance our ethics with the dollar sign. And this is a cartoon. Okay, you can have a smile over it. A 34% cut in our corporate ethics should return us to a profitability. But quite honestly, at times we do feel like we are being pulled to that level of thinking. And again, as another problem, as a rehab physician, we have to answer this question: how many years of a non-disabled life is worth how many years of a disabled life? So this is a difficult questions that we have to balance in our practice day to day, particularly the ones when we deal with patients who have got likelihood of advanced disability. So what is neurorehabilitation? Just to bring the ethics together to the neurorehabilitation, for those who are not very familiar with the specialty, I just want to give you a very brief overview of it. It is a complex medical process which aims to aid recovery from a nervous system disease or injury and to minimize or compensate for any functional alterations resulting from it, meaning management of disability. In case of a serious disability, such as caused by a severe spinal cord injury or brain damage, the patients and their families' lives are suddenly shattered. In order to cope with this, a new way of living is established by individuals and their families with help of neurorehabilitation teams. This process or journey often poses significant ethical issues and barriers. Individuals who have to be managed in a state of disordered consciousness are most vulnerable, and it is in this context that we pursue some discussion and debate today. Ethics does not provide absolute or final answers, but aims to raise awareness to improve contextual behaviors within the binds of the moralistic professionalism. At the end of today, I hope you will have more questions than answers, as this will generate further understanding and improvement in the standards of care. So, ethical consideration as it pertains to neurorehabilitation, that the traditional medical ethics has largely been developed in the context of acute and immediate care, so or end-of-life care. But there is a large spectrum of care that we have to provide to patients from the point of disabling condition, impairment developing, and for the rest of the life continuing. Rehabilitation is a more protected engagement paradigm. Rehabilitation ethics should therefore bear different emphasis. So differences between the traditional medical ethics and rehabilitation ethics, as I see it, is that in rehabilitation, we have to show respect for person autonomy rather than patient autonomy. So they don't have to just make a decision whether they want to have a surgery or they want to have certain medication or not. They also have to make a decision whether they would like to give up what limited walking they have and would want to take onto a wheelchair or do not wish to be seen in a wheelchair. And those sort of autonomous decisions have to be made by the patients who are able to make them and retain capacity to make them. Active treatment participation contract rather than passive acquisition model. So that what that means is that in rehabilitation, patient is part of the treatment model. They are inside the sphere of the treatment and not passive recipient of just medications being dispensed and given to them or surgery being done to them. They actually have to participate in therapy sessions. They actually have to day in, day out, work hard with therapists, with the neurorehab doctors, with the, for that matter, home-based teams to reintegrate back into society. It is an educational or process model of consent rather than a contractual or event model. So it is not one episode model. It's not just an appendix being taken out. It is a day in, day out model. You might have to renew your consents relatively frequently. An intimate role for the family comes in rehabilitation that can blur the distinction between the family and the patient, but this should be done without losing person's role and decisional independence. There needs to be a greater honesty about quality of life judgment and prognosis, and there should not be any imposition of extraneous values when you're providing rehabilitation, because we are not here to repersonalize patient, we are here to rehabilitate patients. So just taking you through another little aspect of ethics, that in every rehabilitation case, we have to be case specific. We can't have a generic model of ethics imposed on a whole rehabilitation team practicing for all patients. So casuistry is a science, or is a case-based ethics, where the casuists claim that the ethics is primarily a matter of attention to details or circumstances of each case. In order to launch and maintain the process of case-based ethics, rehabilitation service must become institutionally conscious and manage each case within ethical framework pertinent to that case. All rehabilitation teams should acknowledge that each case has some ethical issues. In each case, the emphasis and considerations are largely around longer-term outlook and final outcomes. Judgments are required to be made in the context of several months or year or two down the line. Change a person's role is severe, needs to be handled with utmost righteousness and without bias. Protection of the rights of person affected must be central to care planning. This is most required in persons with disorder of consciousness. When a person is in a state of disordered consciousness, person versus family and person versus corporate issues must be handled as if she was pursuing it himself or herself. In other words, best interest. So coming down to the persons with disorders of consciousness. In the case of persons with disorder of consciousness, the ethical issues become more challenging. Disorders of consciousness can be severe cognitive impairment even, but what we mostly understand is a minimal conscious state, vegetative state, and coma. For the purpose of this discussion, we will have the patients who are not in a cognitive impairment status, but in a non-responsive or a minimally responsive status. What are the unrepresented individuals with disorders of consciousness? In this day and age, with expatriate residents, immigrant workers, travelers, and refugees, we often see patients brought to ED departments with no accompanying relatives, often alone by ambulance staff. With conditions such as stroke, head trauma, and encephalopathies, an individual may not be able to provide consent or make any other decisions due to the disorder of consciousness. The emergent and life-saving decisions are made by the emergency and acute care physicians, and relatively easy to make them. I wouldn't say easy, but it's relatively more smoother, and the processes exist how to make those decisions in these patients' cases. But life-enhancing decision, on the other hand, and plan, who makes the decision and how? This is our concern for today. So ethical, first of the thing is autonomy. We will take that. Consent, you will hear a detailed talk on it by Dr. Ahmed. Surrogate decision-making, we're going to discuss that. We will talk about emergency versus rehabilitation decisions, neglect issues, goal setting, and rehabilitation outcomes. So next few slides, we're just going to talk about decisions, how the decision-making should happen. So the core principle of ethics is an autonomy of the patient, not possible to exercise as patients with has disorder of consciousness, and the decision making cannot be extended to someone who knows him or her as he or she is unrepresented. In other words, the person cannot make decisions for themselves because they are unable to engage in any form of interaction, and then they do not have anyone who knows them to tell you about their preferred choices or what they were like before. So you have a person you have to make a decision totally in the dark about. There are decision-making models in such circumstance. the treating team has to make short to long-term decision based on the best interest. So it's a very interesting advice that Benjamin Franklin gave to his friend, the British scientist Joseph Priestley. He said, "My way is to divide half a sheet of paper by a line into two columns, writing over the one pro and over the other con. During the 3 or 4 days consideration, I put down under the different heads short hints of the different motives that at different times occur to me for or against the measure. I find at length where the balance lies, and if after a day or two further consideration nothing new that is of importance occurs on either side, I come to a determination accordingly. And though the weight of the reasons cannot be taken with the precision of algebraic quantities, yet when each is thus considered separately and comparatively, and the whole lies before me, I think I can judge better and am less liable to make a rash step. In rehabilitation, we have a little bit of luxury of time as against in the emergent and emergency situation to be able to ponder over a decision over a day, or at least over a day at least. So should we apply this process? Just a tongue-in-cheek, sure, it's not just Benjamin Franklin. Look at what Charles Darwin did when he was going to get married. This is a quite interesting pro for getting married and not getting married. If you see, the yellow side says not to marry, the pink side says to marry. And he goes through each elements: having children, not having children, someone to care for, someone to not to worry about. So this process of decision making, what I'm trying to say, exists and existed for some time, and we could actually develop a model whereby we can, as rehabilitation teams, start looking at a little bit more detail and not start making a decision immediately for a patient who is unable to engage in decision making themselves. So the questions with respect to decision makings. When this situation arises, we call it surrogate decision making. How should these be made? How is the surrogate decision maker appointed for an unrepresented person with the disorder of consciousness? Should there be a surrogate decision maker advocate appointed by the hospital or by the court of law? If so, who should be appointed to do this? Should hospital have a legal duty to do this through an established and agreed process? And if you do that, for how long? For what matters should a surrogate decision maker be engaged? Medical, financial, employment, travel readiness for repatriation if your patient is in a distant country, legal issues, long-term care, futility, and end of life. So these are all very complex issues, and we need to work out as a rehabilitation team how to engage a surrogate decision-making process or a surrogate decision maker if one exists. And another question that arises is, should each country be instructed by WHO to evolve a legal framework for the above situation? Within the realms of the legal issues, should we have a process where a person who actually happens to be unrepresented and fall into a state of disorder of consciousness, an automatic legal representation is provided? When is this required, and how to arrange this, and who monitors it? So it's another complex there, because in my experience, we find towards when we have a person to be repatriated, we suddenly find that a person has a bank account and a bank loan, and he cannot leave the area until that is attended to. So what I'm saying is that should a person falls into this situation, we should have a ready framework as to how to handle this. Who decides in the best interest of this patient? So there's a question, whereas how do we come to a conclusion that what we are doing is in the best interest of the patient? Is it our clinical thinking, or is it our social thinking? Is it our ethical thinking, or is it our kind heart thinking that actually gets into this process? Is there a living will? We will not be able to find a living will for a person who is unrepresented and with loss of consciousness. Is there an advance directive? The same problem will arise, that we will not be able to access that even if one exists. Quality of life, reason for terminating life-saving care. Who decides what is the quality of life issues in a given person, and whether turning off life-saving or potentially sort of life-threatening illnesses, whether you should treat those or not. Who decides that? Treatment for and these are a very difficult question. In some countries we have law not to withdraw treatment. In other countries we have law that through medical consensus treatments may be withdrawn, but we don't have across the board proper understanding of what do we do. And as rehabilitation team, we are treating a patient, suddenly patient develops a pneumonia, and we call the hospital internal medicine doctors, acute care team doctors, and we get different responses. We don't have a solid way of pushing forward with these situations, especially in the hospitals or the rehabilitation hospitals, where most of these patients lie. We do not have ethics department or other such support systems. So when we do receive a patient with unrepresented patient with disorder of consciousness, the first thing that we must do and must enact, first principle, is beneficence. And in this context, we need to understand from rehabilitation point of view, for instance, intensity of rehabilitation. Do not continue life-enhancing interventions on the basis of perceiving futility, but do so only after futility is established. So basically, sometimes in certain places, people say, oh, we're not going to treat this patient. He's got very poor prognosis. We should have a proper assessment process and a proper treatment planning process in order to disengage a person from life-enhancing interventions. Do not prioritize financial aspects of rehabilitation over person-centered rehabilitation. Discontinuation of rehabilitation as too costly on the basis that it is too costly for a possible given outcome. Analytical transition from active rehabilitation to palliative or supportive rehabilitation status. We need to understand how we have to transition a patient from one level of rehabilitation to a next level of rehabilitation. We need to have episodic review for spontaneous improvement and readiness to upgrade the status. We need to prevent complications, and this is core principle of beneficence. We need to prevent discomfort, malnutrition, complications, and pain, prevent harm, deal with medical legal aspect of rehabilitation with justice and without bias, and secure person's right throughout the course of rehabilitation. So from the beneficence point of view, essentially you provide the treatment as required until and unless you as a team come to a conclusion through proper discussion that the continuation of life-enhancing interventions is futile. And that should be properly documented and placed in the note, and preferably where the hospitals have an ethics department, they should be engaged in that when you do come to that decision. And also make sure that your financial pressures do not overtake your thinking over the patient's rehabilitation prospects. Okay, so this is the beneficence component. Now we go to the non-maleficence component. It is important do not prolong futile rehabilitation for purpose of profit. So I have seen that patients can be given where insurances continue to pay or the funders continue to pay the money. Totally needless rehabilitation can be prolonged for months or years, and knowing well that a person is unlikely to profit or benefit from it. Do not delay withdrawal of supplanted care for concern of reduced tariffs. For example, a tracheostomy tube in some cases may not be removed because it may cause drop in monies that you get for that patient care from the payers. So your decisions making should not be based upon financial gains or losses. Do not neglect on basis of resource limitations or restrictions. Do not allow for preventable complications such as contractures, pressure sores, etc. to occur. Do not over-medicate for ease of care. So if a person is restless or difficult to handle because of spasticity or other measures, do not over-medicate the patient. Find means and ways of getting a right balance between medications that you provide and the supportive care from physical point of view that you can give to reduce the burden of medications. Do not confine patients to bed because it is too cumbersome to sit them out. Do not allow exploitation from the legal point of view I'm talking about, financial point of view, and other such matters. Then comes the issue of justice. Justice in the context of medical ethics revolves around fairness, balance, and compatibility with the law and patients' rights. Distributive justice is concerned with the fair allocation of medical resources and benefits among patients and society. Equal treatment of patients, ensuring that healthcare providers do not exhibit biases or preferences in delivering care and treatment. Justice embodies the importance of adhering to legal and regulatory requirements in the medical field, and justice emphasizes that healthcare professionals must remain in compliance with the law and consider patient rights while making clinical decisions. And one of the primary reasons why justice is so important in medical ethics is that it promotes equal access to healthcare. Now, when we talk about that in the context of the disorder of consciousness, so in the patients receiving rehabilitation of an underrepresented person with disorder of consciousness, justice serves to prevent neglect. That is the important component. If, for instance, an unrepresented person with disorder of consciousness is developing preventable complication, then justice is not being done, and in the eyes of law, his or her rights are being violated. If an unrepresented person with disorder of consciousness develops malnourishment, the right to adequate sustenance is being violated. If an unrepresented person with disorder of consciousness is placed in a facility that is inadequate for his or her needs, right to safety is violated. If an unrepresented person with disorder of consciousness is submitted to unnecessary or untimely medical interventions, for example, early placement of PEG for reason of moving a patient out of acute care, right to appropriate medical treatment is violated. If an unrepresented person with disorder of consciousness is placed on allowed natural death directive prematurely, right to life is violated. So you need to understand that in the context of patients with unrepresented patients with disorder of consciousness, the justice become a very paramount and a very powerful tool in order to make the right decision by the patient. Now, the final I put the final sort of principle of, and it is an added principle of ethics, is trust. In the context of neurorehabilitation of an unrepresented person with disorder of consciousness, trust is difficult to establish as person involved is incapacitated such that she is incapable of evolving experiential belief in someone or team or a facility that is necessary to build trust. So how do you do it if a person himself or herself is incapable of building trust? In this context, it is the responsibility of those who are attending to an unrepresented person with disorder of consciousness to develop a mechanism that ensures trustworthy processes and policies. These should be carefully formulated and should be open to external and independent scrutiny. The rights of unrepresented persons with disorder of consciousness must be agreed and written down over and above the rights of all. What it means is that when you write, when you go to hospitals, you see these large boards, the Patients' Rights Board. And that is okay for the Patients' Rights Board for those who are represented or those who are able to understand those rights. So over and above, we need to develop a rights board or rights sort of charter for the patients of the persons with disorder of consciousness as well, who are not represented. Somehow we need to work on that parameter, those issues. And I know our president, Professor Homburg, is here, and this particular point is to bring to his attention bodies such as World Federation for Neurorehabilitation can indeed lead the way and begin to define these rights and have them recognized by all healthcare facilities around the globe, perhaps with the help of World Health Organization, who I know we work closely with. So finally, just an ethical message that all rehabilitation teams should acknowledge that in each case there will be ethical issues. This indeed is more pertinent in the context of unrepresented persons with disorders of consciousness. In each case, the ethical emphasis and considerations must be persons' rights and justice. In neurorehabilitation, final outcomes and judgments are required to be made in the context of several months or year or two down the line and not based upon the outlook of over the next few days or few weeks. This places special responsibilities on the shoulders of neurorehabilitation teams. Decisions require a broad-based experience, and senior members of the team should be responsible for making, reviewing, and implementing ethical decision. All neurorehabilitation teams must possess all essential knowledge of ethics relevant to attending to unrepresented patients with disorder of consciousness. Thank you. So I come to an end with that talk. I think we'll leave the discussions to later. And I will move straight to our next speaker. Very much, Dr. Mahwish, I'll give you a brief review, introduction. You can hear me, right?
Yes.
Right. Okay. So my screen is not shared anymore, right?
No.
Okay. So let me just give you a brief bio introduction of Dr. Mahwish Ahmed. She's a physician by training and has recently joined Cleveland Clinic Abu Dhabi Quality and Patient Safety Institute under the leadership of Dr. Jeffrey Champman as the program lead for clinical and organizational ethics and chairs the Clinical Ethics Committee at CCAD. She has been serving as a staff ethicist in the Center for Ethics, Humanities, and Spiritual Care at Cleveland Clinic Main Campus, Ohio, for the last 5 years. Bioethics after she completed a 2-year clinical and transplant ethics fellowship within the Cleveland Clinic Center for Bioethics, and carries a healthcare ethics consultation certificate from HCEC Certification Commission. Before her time at CCF, she completed her master's in public health with a concentration on health policy and hospital management and family and adolescent health at Columbia University in New York. As a physician, she completed her medical training in Pakistan. At Cleveland Clinic Abu Dhabi, she is hoping to jointly cater to the clinical ethics needs of physician, nursing, and caregivers, colleagues, as well as leading the policy support work for organizational ethics asked for the optimizing patient care. Dr. Ahmed has previously also volunteered a time to the network of organ sharing ethics committee representing Ohio, Michigan, and Indiana at the national level for transplantation ethics policy work, as well as the Cleveland Lerner College Medicine's diversity, inclusion, and anti-racism steering committee in effort to support and gain visibility for diverse teaching faculty and trainees at the clinic, with a larger aim to make medical education overall more culturally sensitive and inclusive for all. She's passionate about research around disparities within transplantation, organ donation, living organ donation, and ethics around end-of-life care and moral distress within transplantation decision making. So she's going to talk to us today. Thank you very much, Dr. Ahmed, for being with us today. And she is going to talk to us today about decision making on behalf of underrepresented patients with disorder of consciousness. Thank you.
Thank you so much, Dr. Wasti. Justin, if we can move to our next slide. Thank you. So it's my pleasure and honor. Thank you for hosting me. These are my disclosures. I have no affiliations except for place of work. As mentioned before, I am the program lead and the chair for Clinical Ethics Committee at the Cleveland Clinic. Next slide, please. And so Dr. Wasti has built a strong foundation in terms of our listening audience for what bioethics is. Next slide. Bioethics is the multidisciplinary branch of applied ethics that studies the philosophical, the social, and sometimes legal issues that arise in medicine and the life sciences. Many of the subdivisions within medical ethics that I grew up in terms of training are to be seen in front of you on the slide. Next slide, please. So today, from a perspective of unrepresented patients and how to sort of start to think about what the practical applications of the 4 primary principles of bioethics are that Dr. Wasti elaborated upon, we will be specifically focusing on bedside and consultation in terms of specialty interests, especially as it pertains to neurorehabilitation. Next slide, please. And so I just wanted to give a flavor of what a bioethics consultation service looks like. We are sort of trained ethicists, and myself and my ethics committee devote time and attention to not only organizational asks by our hospital, but also to sort of further the ground for such lingering challenges as we find in terms of underrepresented, unbefriended, or patients without surrogate, as we call them within our system. Next slide, please. So in terms of when we are applicable and what what constitutes consultation from a clinical ethics perspective, one of the primary reasons that we get called in the hospital are because a patient is themselves incapacitated, is in a minimally conscious state, or is completely comatose, not able to speak for themselves for whatever reason, or intubated, sedated in the moment, and no family has been available for the past some time in efforts to collaborate with them to further care for the patient and to decide what the next best steps would be. Next slide, please. So when we arrive, usually things look like this. Next slide, please. And sometimes when we arrive too late or are consulted rather late in the process, they can mimic very much the scenario that you see in front of us. Next slide, please. And so the ethicist's job sometimes is to do a quick untangle of all of the challenging dynamics that have been happening at the bedside, the lack of agency because the patient is unable to speak for themselves, and to sort of quickly bring back focus on what we can do in terms of best interest standards for the patient and to put them prime and center in order to further their care. Next slide, please. And next slide, thank you. And so I'll sort of start our practical application by going over the 2018 Disorders of Consciousness recommendations given out by the AAN. Next slide, please. Which highlights some of the lingering ethics challenges that we face as a field in terms of who makes decisions for incapacitated patients, especially those who have not designated a surrogate through an advance directive, who do not have a living will, and unfortunately, we are anticipating a fair period, if not a permanent period, of lack of incapacity because of their inability to engage with their environment or because of a minimally conscious or an unreliable state of consciousness. Next slide, please. And so I would like to sort of bring us back to the ethics around this topic in terms of what these practical guidelines are, directing physicians and ethics professionals to do, and mark an important turning point in the care of patients with severe brain injury. And as clinicians, as Dr. Vasti elaborated, and especially health systems implement these guidelines, there are, some severe lingering challenges in terms of ethics proportions on how to assess the benefits, the risks, the harms, the feasibility, and the cost of recommended interventions that are forwarded by the American Academy of Neurology here, in concert with the American Congress of Rehabilitation Medicine. So next slide, please. So we'll sort of go over very quickly what their proposed recommendations are. Thank you. Next slide. And start off by mentioning that from a practical perspective, decision-making capacity, even though we, colloquially know that the patient might not be able to have full decisional capacity, a formal evaluation is sometimes necessary, especially when we talk about minimally conscious states and or in states where the patient is able to have sporadic sense of their environment. Next slide, please. In usual cases, for patients with minimally conscious state or for chronic vegetative states or full on lack of consciousness through coma for extended periods of time, in usual cases we would be involving their family, would be involving the appropriate surrogate decision makers in the prognosis and recovery conversations that we're having on behalf of the patient, even if the patient is not able to engage in them himself or herself. Always, I tell my clinicians whenever we're called to just go over the simple steps and hierarchy of questions. And one of the main ones to always ask is, what are the patient's prior expressed wishes in this or any regard that would have any bearing on their medical care? Always make a good practice of asking about advanced directives, even those that are far in the past. Sometimes families tend to think that from a legal perspective, only things that are written down or paperwork that has been done within the last year or so might be pertinent. So always good practice to check and see if in the long there's been a long duration, but there is some form of advanced directives or a living will is available for the patient, which would have a fair bit of reflection of what the patient would have wanted or would not have wanted for themselves, which gives guidance and provides a boosting effect for the surrogate decision makers, even if they are close family, to make sure that they are going by what the patient would have wanted, thereby instituting what we call within the ethics world a solid foundation for the substituted judgment standard, which aka in short term means, what would the patient want if they were able to talk for themselves, what would the patient want if they were able to decide from themselves. And that's sort of the framework that we want the family and the surrogate decision makers to move from. However, when it comes to patients with disorders of consciousness that do not have represented family, or we've been unable to locate them because they've either come in on an emergency basis as a John Doe or a Jane Doe, for example, in the US and in Canada, or as a patient who is unrepresented at the bedside, as in the UAE clinical picture where we practice. The bedside need of the moment, aka medical acuity, surgical need, and feasibility of the moment, and married with the best interest standard, are utilized instead, given the lack of family and advocates at the bedside. Now, however, this can lead to a lot of inconsistency, a lot of trepidation from the clinicians themselves, given that they do not know the patient primarily or do not have a long term relationship with them, and find themselves in the uncomfortable hot seat of having to decide for someone who's not able to weigh in and tell us what they would have wanted to do. So, in the slide in front of you, I apologize for the heavy slide, are the recommendations provided by the AAN in terms of having these patients, especially with quantified disorders of consciousness, to have when they have medical stability, be in settings where multidisciplinary rehabilitation teams with specialized training are available. And these clinicians are then recommended to use standardized neurobehavioral assessment measures in order to make sure that the diagnostic piece of this puzzle is as standardized as possible. Also, a prompt by the AAN to reduce the diagnostic error in individuals with prolonged disorders of consciousness by use of serial standardized neurobehavioral assessments and tools in order to assess what would be the feasibility and cost relative to benefit in terms of where the patient might lie. Um, Clinicians should also, they recommend, attempt to increase arousal before any of these assessments are done, so as to provide the best baseline possible for the patient for the first time or the second time that they're assessed, and to identify and treat conditions that might confound accurate diagnosis. So some early on acute steps are provided by these recommendations. Next slide, please. However, there are, of course, limitations to all recommendations provided by any society, especially when it comes to a situation where the patient themselves are in the situation of not being able to tell us what they would want because they are unable, by virtue of their pathology, to interact with the environment or even to assess that in which environment they find themselves in. Married with the lack of advocacy from being alone by the bedside, aka family, surrogates, or people who might have known them and their preferences are not close by and not able to give us a sense of what they would have wanted. And so I will point out from an ethics perspective that there's omission of the guidelines somewhat omit a fine nuanced emphasis on putting the recovering patient in conversations and care. Sometimes there is variability in where patients might be, or they are slowly starting to progress. And so for those practical purposes, I always ask the clinicians to make sure that we have bedside conversations so that the patient, even if they are not fully aware and do not have capacity to make medical decisions at the bedside from a legal perspective, are as aware as we can make them, especially if they are thought to have a prognosis that might eventually lead to a lightening of their a disorder, aka improvement from a neurologic standpoint. The other thing that I'd like to point out is that one of the reasons physicians find this questions and how to determine the direction of care for such patients is hard is because we inherently understand that there's a disability paradox at play here, aka there's a mismatch between how healthy observers such as you and I might rate the quality of life of a patient who's never going to be able to walk, talk, engage, read, and go about work versus how they would perhaps themselves self-rate their quality of life and what they would want for themselves. And so because of the underlying uncertainty of values, of what are our values and how we project them onto the patient, there's nobody to help boost us. And whom should we ask? Who should be the person from a legal perspective or from a policy perspective who should be working in tandem with clinicians to make these decisions? It becomes a challenging, a challenging scene at the bedside. And so some of the ethical challenges that the guidelines highlight are in front of you, and they have provided potential guidance in terms of how to manage some of these prognostic or diagnostic uncertainty. For example, they prompt us to meet with the family if family is available multiple times. In lieu of this, for underrepresented patients, I would say that team meetings are very necessary to make sure that, especially as we have a more rotational model for medicine coverage in this day and age, we want to make sure that our colleagues and the people who understand the patient's diagnosis and eventual prognosis deeply are on one page with us in terms of where we are and what the best benefits for the patient might be. And the other thing that I would like to highlight is that for many institutions who have the privilege of having and have access to a clinical ethics committee or a clinical ethicist at your behest, please consult them so that they are aware and can help advocate for such patients. Within our healthcare system at Cleveland Clinic main campus, and now increasingly at Cleveland Clinic Abu Dhabi, we are setting up a system where we have an advocacy channel through the clinical ethics committee so that one of us is shadowing the patient and involved in care, ready if there are any care decisions that might be needed, especially so that we do due diligence and, as Dr. Vasti elaborated, provide beneficence, non-maleficence, and justice from a clinical care perspective within the context of timely decisions made for the patient, so that there is no untoward delay simply because there is no family to advocate for these patients. So next slide, please. In terms of feasibility for these patients, sometimes when family is present, there can be some challenging conversations about, well, we don't want to go down a route because you don't think that there's enough chance of progress here. Families can sometimes perceive that as value-laden judgments, and they tend to conflate our sense of medical feasibility, which is AKA cannot be achieved, with terms of practicality from their perspective of, well, it's not worth it, quote unquote. And so it's important to adopt a sort of hub and spoke care delivery model, and also meet with our colleagues frequently in order to help have a narrow understanding but a solidly determined one in terms of where we think this patient is going, how much recovery potential do we think they have, and when it comes to making long-term decisions for neurorehabilitation, what would work in their best interest, and how we should proceed in those terms. Next slide, please. And so clinical assessment for capacity as disorders of consciousness might be alleviated or moved towards being I guess towards progress. I would say that continual assessment of capacity is a necessity, especially as decision-making capacity is understood to be time and decision specific. And so if the patient is improving, even if initially they were in a more disordered state from a acuteness of injury perspective and were burdened with comorbid challenges that perhaps had shadowed part of the disorder of consciousness, it is important as the things fall away and a clearer picture emerges in terms of prognosis and prognostication and the testing available, that we promote this concept of reiteration of capacity assessment to make sure that we are doing right by the patient. Next slide, please. So from a bioethical expertise standpoint, next slide, please. We tend to have a two-physician best interest standard concept within our walls for these patients, bolstered by and nuanced by an ethics committee support process. Next slide, please. In order to provide timely and nuanced assessment of what the patient might have wanted, what would be the best interest of this patient at this moment in time? Should we proceed with X, Y, and Z procedures? Next slide, please. And move forward with what the next steps in care are. Next slide, please. So as to have a balanced proportion, if you will, in terms of beneficence and non-maleficence, not abutting against patient autonomy or justice concerns in this scenario. Next slide, please. And so we meet frequently with patients. Here, I would draw your attention to column C here in table number 2 in the medical principles and practice review in 2001. And so the beneficence, non-maleficence, respect for autonomy model shows us that the quality of life and expected quality of life with and without treatment is an ethics question and a clinical one that is really pertinent to these sorts of patients. What are the deficits, whether they be physical, medical, or social, that the patient might have after treatment, and what from an overall clinical perspective would serve them best if they were able to continue to progress at the rate that they are, or if they're not able to progress at the rate that they are, what would be the way that we would advise them if we were able to. Judging quality of patient from a patient standpoint, not from a clinician standpoint, and we talked about the disability paradox here. And in terms of recognizing our own biases of sometimes as physicians and also as human beings, we have much more extensive experience in how something might pan out than patient might. And so to step away from our own biases in terms of what this picture might eventually look like, and to look solely at what the patient might absolutely need from us perspective, we need to make decisions from that standpoint, putting patient agency and their inability to advocate for themselves center point in the conundrum. Next slide, please. And so from a practical perspective, the ethics service provides conflict management and support at the bedside. Next slide. And so when it comes to the should we or shouldn't we, to physicians or in clinical cases where surgery might be required, getting in touch with your medical director or your department chair and sort of phoning a friend and asking for assistance in helping and saying, let me step away from my patient advocate and medicine hat for a second. Help me think through what you think that this case might need from an objective perspective. We assist with that in tandem with your colleagues. What is an appropriate and inappropriate care in a particular clinical case might be very relevant, especially as we go through the spectrum from coma to chronic vegetative state to minimally conscious state to someone who might just have disordered consciousness because of injury or organic disease. And so the limits in resuscitation and the procedure need perhaps are the key things that we pay attention to. And it does end up being a case-by-case assessment of what the patient in front of us might need or what would work best for them in this particular case. Now, for repatriation or patients whose families are not able to be at bedside but have a framework for having them go back home and have services there, that sometimes is an easier model, however, a practically challenging one. We just want to make sure that we are not setting up any unrealistic expectations, especially as we move them through that journey. So next slide, please. Next slide, please. Thank you. So in assessing the ethical situation, I would just sort of bring it back to what the patient or the patient's family's narratives might be, what you know about the nationality, what people who are not legally decision makers that can stand in for the patient, but are overall available. So for example, in the US, state laws vary widely in terms of whether a close friend might be a legal surrogate decision maker that can be appointed in tandem with hospital efforts, or can seek guardianship of such patients who might be thought to have disordered consciousness for a lengthy amount of time or might not be facing eventual recovery. And so to make more challenging end of life decisions, sometimes we rely on the patient's friends who, even though legally they cannot be as a stand-in for the patient, but might be able to provide us with very straightforward and very accurate assessment of what the patient might have wanted for themselves, or whether they had ever had a conversation with that particular person. And so having collateral information about where the patient is coming from and what their delineations of care have been in the past, what their inclination for seeking care has been, are some things that we need to put prime and center while making these decisions. Next slide, please. And so for those shorter term and low stakes conversations and decisions, that can be a framework or model. What we really do get muddled up in, though, and sometimes this can be acutely challenging, is when the patient is facing an end of life question, and you're literally at the fork in the road, and you're thinking, well, the patient can't make this decision. Do I have any legal or moral standing for moving forward in a path which they might have fully disagreed with? Next slide, please. And so in these cases, we tend to err more on the side of caution, if you will, and provide care unless told to otherwise. These are cases that in the US sometimes go to the escalation pathway for hospital leadership to delve into, or for the courts to provide a court-appointed guardian, which sometimes can after much advocacy. Granted that post-COVID, many of these pathways have slowed down substantially, especially in the US, given that probate courts are overtaxed and have a pileup of cases. But there are certain support structures that are possible for patients who truly are alone, and we have cast a wide net through case management, social work, clinical colleagues, and trying to do our best to find somebody, and nobody has been located. And we have acute challenges and important decisions to make in front of us. Then the hospital does sometimes have mechanisms to get in touch with the legal office and make sure that we have advocacy towards getting somebody approved and appointed who can be a stand-in and help us make legal decisions that can only be done by the patient or the family. Next slide, please. And so I'll just bring us back to the role of bioethics within the hospital setting. Is one of support, one of advice. We are an advisory committee and an advisory service at the best of times, and your ally in terms of helping you walk through these challenging courses. Next slide. And so in terms of the key takeaways, I would say that ethics helps advocate for judicious and fair allocation of resources. Sometimes these can be really hard, high stakes, challenging cases, which are really protracted and long drawn out. And so we help the teams in balancing these burdens and benefits, sometimes where people find it really morally challenging to be treating patients in a way that they would never want themselves to be treated, or to be quote unquote kept alive when they would think that there is no chance or hope. And so ethics is available as a recourse for those moral conundrums, for those disparities in access challenges or allocation choices that might need to be made. And then, of course, we collaborate with our consultation model and engage with moral distress work, which can be a load off for teams who are struggling with such patients. Next slide. And so as we've mentioned before, clinical cases, given how intensely challenging and complicated these questions can get, especially if you have an end of life concern in front of you for a patient who's unbefriended or unrepresented, and nowhere to share that information with, can also be a source of moral distress for our teams. And so your ethics department or your clinical ethics committee might know of resources within your hospital systems that can help target that and sort of debrief in order to reduce some of that load. And with that, I will ask for my next slide. Thank you so much for joining us this evening or morning in your case, if you're joining us from another area of the globe. And these are my sources. Thank you so much. Last slide, please.
Thank you. Thank you, Dr. Ahmed, for very I would say extensive and much needed overview of a very complex subject in a very short time. Thank you very much for bringing it together. I think we can now move to a bit of discussion and question answer. I've been just been told by the technical team and the organizers, we're running a little bit over weight, but they're very kind to allow us a little bit of time. So we open the sort of forum for those who are attending can write their questions in the dialog box and shoot it to us. And for the panelists, we can actually have the luxury of talking over the microphones. So I open it. Thank you very much for all the panelists, and let's have a little bit of a debate. I think we will raise more questions than answer at the end of all this, and that is what the role of ethics is.
Okay, I don't see anything in the chat room and the Q&A at the moment, so I take the liberty in making some comments, if I may. But you're the chairperson, so I'd say, first of all, I think what we have alluded very much to is the extension field. Medical ethics, of course, we're always concentrated on the patient or the person. And especially when it comes to disorders of consciousness, you have to widen this field that the person is not the person alone, but you have a surrounding or an environment of the person. And then, of course, a lot of problems arise, which is an allowed environment, a good environment, not a good environment. That is not really solved. That's for sure. The second, and I think I would briefly allude to that, is a very important issue. We were talking about prognosis, prognostication, especially in the field of disorders of consciousness that can be very intriguing. In neurorehabilitation, we are now discussing a lot about biomarkers and better prognostic, let's say, information we can get from all sorts of neurobiological, neuroimaging, whatever have you, information. But that, of course, is a very, very difficult ethical question. So if you come to a point to say, well, this particular individual patient, when you apply the justice principle of medical ethics, for instance, has not a good chance to improve, whereas another with a different setup of biomarkers may, in actual fact, have a better chance. Nevertheless, we know that all of these biomarkers are never 100% true. There may be 50% or 35% or 80%, some of them. What are we doing with that, with this? So the entire discussion about prognosis in an ethical sense can be extremely difficult. And we don't have clear delineations how we are going to deal with that. And we have to, I can't give an answer to that, but we should think about that, because that is coming up more and more, because the available biomarkers are increasing, okay? And the pressure, of course, on the system in terms of justice application, of course, is also increasing. And we cannot anymore what John Rawls called the veil of ignorance put around us and say, well, we start with a very early starting point. We have to think about that. And I think that is certainly becoming more and more a very important issue. And the third comment, Malish mentioned best practice as a good standard, of course, for dealing with these patients. But we must accept that many patients do not accept best practice standards as that what they want to have. A good example is if you have a patient with a severe dysphagia, if you put an NGT or a PEG in, which is probably best practice, but nevertheless, the patient, no, I don't want to have this. I want to have any artificial type of nutrition, and I'm against that. How are we going to deal with that? So there's a clash between best practice and what the patient's desires are. So we have a lot of many unsolved questions. And what Sabat asked me, of course, WFNR is always happy to come with our ethics committees and other committees we have to a better definition, a state of the art of ethical standards. No doubt about that. We are very much interested in it.
So thank you very much for. I think the immediate questions that are posed to the neurorehabilitation teams in the context of a person, particularly unrepresented unconscious patients or disorder of consciousness, is, for example, if they could be exploited, the patient could be, I have seen patients being placed on robots, tied up, and walked and thinking that this person was going to walk if they're or they're having their arms moved through robotic arms, and we have no ethical directives to the clinicians that when do we, these potentially life enhancing interventions, when do they become futile? Where is the line of futility arise?
Yeah.
And we don't have definition of futility in neurorehab as much. And then repeated interventions over and over again. And equally on the other side, if the person does not have access to such luxuries, they can be exploited by not being provided all the interventions that could help them. So these are the issues that sort of trouble me as a kind of ethical. I actually have a very me. I become a person's patient's unrepresented patient's advocate subconsciously. I've developed that, but I don't know whether it has come over years of practice and things that I actually go along. We are very lucky to have a very ethics sort of strong ethics committee at Cleveland, but not all hospitals have that. We are a global federation, so we know that certain hospitals probably do not understand what that ethical aspects of practice are. So as a WFNR, we need to sort of develop a code of ethics for the practitioner, neurorehabilitation doctors to understand, both from sort of what we call financial aspects and clinical aspects to when we're dealing with unrepresented patients with disorders of consciousness. As regards the acute interventions, when to place a peg in and when to sort of mobilize or not to mobilize the patient, I think that's relatively, we could put some guidelines to that as well. And there are guidelines to that, but we can bring it all together in one document and circulate it around. Well, we have one question. This is Karim Sharif from Saudi Arabia. Yes, please. Have you the question, Karim? I just please type your question. Dr. Ahmed, you are from the rehabilitation point of view, we make longer term decisions. That is one of our problem. And I know that in the acute setting, the ethics kind of developed a very decent set, especially in states. I know they're very strong, the ethical aspects of practice. But are you aware from this practice in states about neurorehabilitation component in a more protracted dealings with patients with unrepresented or even disorders of consciousness with advocacy available? Whether there are any written guidelines for the rehabilitation physicians? I'm sure if you haven't been involved in rehab circuits, you may not know it, but are you aware of it? If not, then we can seek it out. Because I know USA is very tight in this case, in such circumstances.
I would advocate for us seeking it out. And I think having a more global perspective on this is absolutely needed. I mean, this is a perennial question in the ethics world, right? Not just for neurorehabilitation, but also for all unbefriended patients who have sometimes massive end of life challenges. And COVID, I think, sort of pushed us towards the curb of of urgency of having to find a solution as a medical community, not just with the neurorehabilitation, but overall in terms of what I read more and more from the US as an epidemic of loneliness. Our global model for living and aging is changing. And as we make those leaps and bounds, for better or for worse, I'd hate to comment, but as less and less people know and pay attention to, I think it reverts back to the medical profession to have a good moral compass in terms of what we should be doing when, and what our colleagues would deem as consensus issues that can be more solidified, so that the level of uncertainty and the breadth of it can be sometimes perhaps tightened in order to help us do and you guys job at the bedside. I am not aware of any specific neurorehabilitation guidelines on this particular topic. Most of the challenge remains also is that you need a duality of efforts, right? There's the medical community doing its efforts in terms of providing consensus for what should be done in those hardest of cases. And then there's also the legal systems that need to be brought along in terms of if we are seeing a preponderance of numbers and increasingly so of patients who are coming in unrepresented, or patients who for the longest time have been living independently and unfortunately had an acute insult and then had to come in, then we need to cater for them. A more facile advocacy option for patients so that designated legal guardians can be provided to them is absolutely needed. I think there's no two ways about it, especially in the US, as most globally our communities and our populations age. I think it is an imperative that we face within this realm and others. So I think to have this group be an advocate for such change, I think would be a great benefit.
Thank you. I think we don't have any questions, so we will put ourselves to tasks on this one. And I will take the responsibility of taking this work forward. And I think it is very important work to bring some form of discussion to the fore, which should lead to development of some guidelines at the level of World Federation of Neuro Rehab. I'm sure Professor Holmberg will support us on this one, and it should be a good body of work. And if you, Dr. Ahmed, we can use your sort of experience and resource to support us in that one, that would be great.
I just want to mention that of course, we are talking now about situation in the United States and the Emirates and in very rich countries. And the situation in other countries is completely different. And of course, for these, we also need clear and unitary standards. And it's certainly extremely difficult to find unitary standards which have a universal applicability around the world. That was the idea with this medical ethics today. But nevertheless, it's still a problem. And the justice problems, to put it that way, are certainly much more virulent in low middle income countries. And for the World Federation, of course, it's a real intellectual challenge, let's put it that way, to come to reasonable ethical standards when it comes to triaging resources and things like that. And we certainly have to work on that. But I look forward to it. Sabad is a very good guy in leading this. So we will certainly have some progress soon. But it's very important that I tell you, the WFNR certainly is alerted to that very much.
Okay, so I have a very important contribution from a participant delegate, Assam Javed, and I'll read it out for you. Thank you for organizing this webinar and raising the questions. Just a comment, really. Unrepresented Patients Project for Illinois, UPPI, which was initiated by members of the Institutional Ethics Committee of the North Shore University Health System, a 4-hospital system primarily serving patients in Chicago and North. As of this writing, UPPI has grown to include more than 100 individuals, hospital ethicists, ethics committee leaders, lawyers, and administrators, and leaders of statewide organization representing 30 Illinois hospitals or systems, 15 other relevant. Oh, this is wonderful. So I think we can, if you can let us have your contact further, we would be very interested in learning more about this project and see what are the sort of parameters and what is the structure of it. And certainly we can look into it more. Thank you very much, Mr. Javed. Thank you. Okay, yeah, I think we will take this. We have no further questions. It's been a wonderful evening of ethics. We all feel a little bit better about ourselves now, I think, having been righteous in our heads at least. So without, if there's any further comments, not that, then we can bring this to close for delegates who are joining us. Please see that the organizing committee, the organizers have put a link to get your CME certificates. In there, you'll get 2 CME points. And also, there are a couple of announcements. In February, we shall be doing, please, can you put up the flyers now for January? We are coming or developing an Indo-Gulf partnership in setting up some educational meetings. In February, we shall be doing a stroke rehabilitation, not a hybrid conference type, a symposium, if you may. The 17th of February is the date. Do you have a flyer to put up or not? And then from 8th to the 10th of November, we will be having Indo-Gulf Neurorehabilitation Conference. Both these will be a sort of held in Abu Dhabi and Mumbai simultaneously. So there we go. This wonderful friend of ours, Dr. Nirmal, co-chairing with me the Stroke Rehabilitation Symposium on the 17th of February 2024, and the next one, just get this dates in your diaries, those who are interested. The next one will be in November 8 to 10. If you have that slide, you can put that up as well. This is with the support of World Federation for Neurorehabilitation, of course, and our wonderful president, Professor Homba. Thank you.
My pleasure.
Thank you very much. Okay, if there's nothing else, we can begin to log out. Oh, here we go, the second one. Our second poster for 8th to the 10th of 24, Abu Dhabi and Mumbai. Okay. Lovely. Thank you very much for all your time. And those of over 500 people who remained with us throughout this webinar have been amazing. And if you have any questions, you can shoot them to the organizers and they can put it through to us. Mr. Javed, if you can give us more information about the Illinois project, that would be great. And we will take this work forward. Thank you very much.
Thank you, doctors.
Thank you. Thank you.
Okay, thank you very much, Howard, for setting that up. I think it was very successful, and we learned a lot. That's for sure.
Thank you. Thank you.